screen, can you not? Did I share the screen properly? Yeah, I did. All right.
Yep, looking great.
Yeah.
Excellent.
Well, it's 8 o'clock here, so I'm going to
Oh.
leave it to
Okay.
Catherine.
Okay. Good morning, everyone. It's my pleasure to welcome Dr. Kevin O'Brien to give our grand rounds this morning. He's also our special speaker for our annual RPC retreat, which has to be virtual this year. We were hoping to have him in person, but other plans, and we have to adjust. Dr. O'Brien is professor of medicine at the University of South Florida's Morsani College of Medicine. I hope I pronounced that correctly. He received his medical degree from the University of Miami and completed his residency training in internal medicine at Wilford Hall Medical Center in San Antonio, Texas. He is the Director of Undergraduate Medical Education for the Department of Internal Medicine and Clerkship Director for Adult Inpatient Medicine Clerkship. In addition to his inpatient and outpatient medical responsibilities, his passion really lies with medical education of students, residents, and medical education research. He has been invited to give talks on education, on medical education, nationally and internationally. He has received some 45 awards, honors and awards for his teaching. His research interests center around issues with dealing with evaluation and assessment, the learning environment, and physician trainee wellness and renewal. He promises to share some of his recent research data with us, so I hope Bob is on the line, who always gives me grief about this. Now, I invited Dr. O'Brien because we were anticipating to be starting our CBD, which is not CBD oil, it's competency by design. And this was supposed to start in July of this year, but we've been delayed by a year. But there's a silver lining to that, because we can do a soft start and get this well underway by the time we start next year. And in CBD, there are a lot of work-based place assessments, more than we're doing now. And I would like to see our assessments improve, especially compared to the ones that we get on our ITERs at the present time. And those assessments will help our competency committee immensely. I was very impressed when I heard Dr. O'Brien speak a couple of years ago, and I hope you'll enjoy his talk as much as I enjoyed it. Dr. O'Brien, welcome.
Thank you for that introduction. Today I'm going to talk about evaluation, and I think for most faculty, they get lost in all these terms. Like here in the United States, we use EPAs. Most of my faculty think, or not my faculty, most of the faculty think it's an Environmental Protection Agency. So really what I want the faculty to focus on is just creating a useful, meaningful narrative, and that it's a skill that you learn. It's not intuitive. And when I was in the Air Force, I had the fortunate pleasure to work with Lou Pangaro. And I spent 5 years in the Air Force as an attending. And every month we had to sit down with the clerkship director and give our evaluation on students. And we had to justify the grade that we gave. So if we said a student was an A student, we had to give the why behind that. And we had to focus on skills and behaviors and what we call RIME. And I'm going to explain RIME to you guys. When I got out of the Air Force, I came to the University of South Florida, and I quickly realized no one knew what RIME was. And instead of being at one teaching hospital, we were spread across 3 different clinical sites, separated by 12 miles. Nobody was going to meet monthly to talk about students and residents. And last but not least, you could fill out evaluations any way you darn well please, and no one was going to give you feedback about that. So one of the things that I tried to do when I got here is introduce people to RIME and get them to use the same kind of language to evaluate learners. And I think it's applicable to both students and residents. And the things I'm about to show you really require a team. This is not something you can do individually. And Farina Klock-Sieben has helped me with all the data analysis that I'll show you. Mattel Galloway is the clerkship administrator. She generates all these faculty portfolios that I already shared with Dr. Kavanaugh, and I think she already forwarded to you all. And Robert Ledford is my right-hand person. He helps me do everything within the clerkship. And I think you really need to emphasize that the team is the most important function. And it takes a team, it takes a village to change evaluative behaviors for all your faculty. I have no disclaimers, no financial conflicts to disclose today. And I'm forever indebted to my wife, my family, and my mentors. What I want you to do, and unfortunately, we're not live. Normally when I say this live, I say, all right, I want you to take out your phones, and there's no shame in looking at your phones during the conference. I actually want you to look at your phones, and I want everybody to join in. And in your text, just put it in the to box of your text, put 37607. You do not need to put the hyphen. Then in the message box, just put in USF 2019. It does not have to be all caps. Just type in USF. You don't put a space between the F and the 2019. If you don't have a smartphone, you can use it by a laptop, or you could use it by an iPad, and it's polev.com/USF 2019. And I'll wait for everybody to get in the system. Once you've done it, you should get a response back that says, you are in the poll. I didn't get it. Did everybody get that text response? And there is no data fees for people that are in Canada. It's applicable in the United States and Canada. And I got a message that says, you are in the poll. I know it's backwards, but you all should have gotten that message. So I really want to find out who you are. And if you could just respond and tell me who you are, because I really want to know the audience today and see where you're at. So we have some students, we have some residents and fellows, we have deans, and we have faculty. Is anybody the residency director or clerkship director by chance? All right, so we have both faculty and learners present, and we have administrators present and leaders. Okay. Now, I want you in free text response, give me your personal pet peeves about the current evaluation system at the University of Calgary. What bothers you about evaluations? And remember, everything you write does show up, and there are leaders present. Objective. Cumbersome. Too general. Completely agree. It's just not practical. Asynchronous with the experience. Completely agree on that one. Yep. Yes. For feedback to be important, it's got to be timely, specific, and focused on skills and behaviors. Time consuming. Too many check boxes. Ooh, I'm going to get back to the check boxes. I have some interesting data. Exactly. Square pegs problem. It's not clinically applicable to a lot of things we do. Okay. All right. And it's labor intensive. So I can see a lot of people are, just like at our institution, say the same things. I don't think it's any different from the United States and Canada. We all say the same things about evaluation forms. I'll give you some of my pet peeves. And I was driving to work one day, and this car was next to me, and I saw this license plate. Gotta be a lawyer. Still can't believe to this day. And I was at a stoplight. I was not driving when I took this picture, but I was like, wow. But in terms of evaluations, what I really want you to do is get out of the habit of giving comforting lies. When you're working with someone who you think is struggling or not performing well, you tend to focus on their attitude, and you don't give them specific feedback on their clinical skills. You want to give them those comfortable lies. And I want you to be the gentleman over on the left or the woman over on the left. And I want you to give them the truth, but give it to them in a way that they understand and that they can improve their performance. The other thing that is one of my personal pet peeves, and again, I'm walking to give a lecture on this very topic, and there's someone's license plate, not to pick on the University of Virginia, but I really want you to make a habit of submitting your evaluations within a week of finishing with that student. Most of our faculty periods of time working with students and residents now is 2 weeks. So within that week after the 2-week period, really try to submit that evaluation. And I'm going to give you today a playbook that you can follow. It'll make filling out evaluation forms easily because you're going to use the same format every time, regardless of the learner, and you build off that format. So I can tell you're not satisfied with the evaluation process. And a lot of people, there is no formal process to explain evaluation frameworks to faculty. So I'm going to try to do that today. And then I'm going to give you a platform or a language that you can use to assess student and resident skills. And then what we do with our faculty every year is we orient them on how to do evaluations. And they need the reminders every year. Trust me, even the ones that'll tell you they forget things. So it's important to do this on an annual basis. And then the other thing we really want to do is improve our faculty's performance overall. You want to give them feedback so that there's continual improvement in all the faculty, not just on their evaluative behaviors, but also their teaching behaviors. And trust me, the two are intertwined. Students consider great evaluators and teaching similar. So they're really intertwined. And I'll show you what I mean by great evaluators. It does not mean being an easy grader. So my goals and objectives for today is it's really a dual agenda. I want to improve the quality of the evaluations that faculty submit on students, but I also want to use objective data to motivate the faculty on their performance. And I can't lie, I have to tell you the truth, that I had a dual agenda myself. You saw the roles that I have, and I have to figure out grades every 8 weeks on 25 students. And then every year I have to create 50 Department of Medicine letters of recommendation for residency training. And it makes my job much easier if I have quality evaluations to use to determine grades and to write those departmental letters, which are very important for residency selection. So in the last 12 months, again, another question for everybody in attendance, have you received feedback on the quality of the evaluations you submit on learners? So we've got almost 90% of people saying no and about 11% of people saying yes. And I'm just going to show you some national data that will open up your eyes. We put this on the CDIM annual survey in 2016, and we sent this out to 128 medical institutions in the United States. We had a 74% response rate. And 46% of programs out there are not giving feedback to faculty at all. And remember, feedback, for it to be effective, it's got to be a shared dialogue between the giver and the receiver of the information. So the 17% of programs just sending an email, you don't even know if that faculty member read it or not, or if they actually reflected on it and are going to change their behaviors. And I commend you guys because only a quarter of the institutions around the United States are actually holding faculty development workshops on evaluation like you're doing today. And I'm telling you that you need practice at this, you need to learn the language, and once you learn the language, it becomes second nature to actually do clinical evaluations. So what do we do at the University of South Florida? We meet with all the faculty annually, and I do it at the hospital they're at. We have 3 clinical sites. We have an outpatient site, which is in the primary care clerkship. We have Tampa General Hospital, and we have the VA Medical Center. And I go to each of those sites and I give faculty development on evaluation. I invite everybody to the sessions. It's not mandated that they go, it is voluntary. And we bring portfolios to the faculty to encourage them to come. Now, how do you get them to come? All the faculty really want to hear what the students say about them. So they're like bees to honey because they get a compiled narrative comments from the students for the entire year so they can read about what things they're doing well and what they might need to work on. So that's the honey or the carrot, if you will, to get them to the meetings. At the meetings, we sit there and we review evaluation frameworks. We talk about what is a quality evaluation, and then I do actual group exercises using Poll Everywhere, and I'm going to do this with you guys in a little bit to teach people how to do evaluation and how to rate learners. We're all diagnosticians. All of us love to diagnose patients. And I want, hopefully after today, I hope you'll love to diagnose your learners and figure out what level that they're at. Okay. So we're going to talk about improving the quality of the evaluations. You can see from the cartoon, this is the old feedback sandwich. And I really want you to get out of the habit of the feedback sandwich. It's passé, it's out of date. You really should have the learner do more of the talking during a feedback session. It makes it easier for you and it makes them self-reflect more. You don't want to be on a monologue. You want to share dialogue with that person when you give them feedback. I personally give feedback to all the people I work with at midpoint and at the end of the rotation, and I do it as a sit-down thing, and I say, I'm giving you feedback. I almost want to tattoo it on my forehead so they understand I'm giving you feedback, but do it formally. And I do not fill out my evaluations in front of them. I do that separately from that, but I do give them midpoint and end of rotation feedback. And even before I begin, I give them expectations. So I would encourage you to have at least 3 things you address with every learner: expectations, midpoint feedback, end of rotation feedback. So let's talk about how to improve narrative comments. So evaluating a student is like doing an H&P. It's like patient care. It's a learned skill. None of us were good at H&Ps. None of us were good at taking care of patients the very first time we did it. Oh my gosh, I fumbled around for 2.5 hours to figure out what was going on. And I know a good student when I see one is not helpful for clerkship directors, students, residency directors, or faculty. The effective and efficient evaluation incorporates an assessment of skills, and it has inner evaluator consistency, and it provides helpful comments to improve performance with tangible goals. So I really want you to focus on skills and behaviors and give meaningful feedback to the learner. So if there's anything I want you to walk away from today's discussion is to burn this in your memory banks. This is the holy grail of writing a narrative evaluation. And I want, every time you sit down at your computer to do one, I want you to remember, compare, KSA, rhyme, meaningful feedback. Say it over and over again until you have it as rote second nature. Compare knowledge, skills, and attitude, their rhyme level, and a meaningful feedback. Okay? So I'm going to go through each of those. Now, there's all these different evaluative frameworks that are confusing to me, but I'll give you some of them. I'm not going to talk about developmental frameworks, which is CBD and EPA. I'm going to focus on KSA, which is an analytic framework, which breaks down the learner into digestible parts. And when you say someone is an excellent resident or an excellent student, I want you to think about, well, why are they? And that helps you with the KSA construct. So think about the why behind it, because we're all internists and we all want to know the why question. Even the cardiologists want to know why the patient has chest pain. Why are they in failure? So really a helpful evaluation contains all 3 of these. And I really want you to remember to compare them to their peer group. So if you have a beginning 3rd year student, compare them to the beginning 3rd year student. If they're at the end of 3rd year, compare them to end of 3rd year students. If they're in the middle, again, in the group that they're in. And if they're a 4th year, compare them to 4th years. And from their knowledge standpoint, what's their fundamental medical knowledge? Can they apply it clinically? Their skills, now you guys are proceduralists, but yes, it's more than just procedures. It's more than just technical skills. What's their organization? What's their efficiency? How do they present? How do they communicate with you, the staff, and with patients? How do they reason through problems? How do they apply pathophysiology? So those are all skills that you can comment on in a narrative evaluation. And then attitude, this is where most people will tend to gravitate to when they don't know what to say, but I want you to put this last. And again, compare them to their peer group. Professionalism, team player, empathy, compassion, their work ethic, their compassion, their motivation. And most importantly is, what is their response to feedback? Have you ever given feedback to somebody and they looked at you with like, are you crazy? What are you talking about? Because I've had students do that with me. And that makes me think, wow, Are they humble enough to realize that this is continuous performance improvement? You're not saying these things to actually hurt them. You're actually trying to help them. And I'm telling you right now, if you use adjectives, you'll get that response. If you use terms that focus on skills and behaviors, you will not get that response. And I'll show you guys examples in a little bit by what I mean about that. So I want you to compare the comments on the left versus the right. Why are the comments on the left unhelpful? Anybody can chime in. What's the problem with the comments on the left? And you can unmute and speak.
There are no specific actions you could take based on them.
Yeah, these are the comfortable lies. These are the platitudes that carry no meaning. I don't know how to grade someone when I get these kinds of comments. Now compare the comments on the right, and what do you notice? They actually compare them to a peer group. They're talking about a level. And notice bullet number 3. Someone could have described that student as anxious and timid, but instead they focused on the skills instead. Their presentations are not efficient. They can improve by not reading from a script. And if you think about the first 2 years of medical schools, what were the lectures you hated? Oh my goodness, they read the slides to you, drove you nuts. You're like, why am I even here? You want someone to summarize the clinical data. You don't want them to read the H&P. So one of the things I do with most students, I say, put the H&P down, and I want you to present to me from memory. And that requires them to practice at home. And they really need to practice because proper preparation prevents poor performances. And then look at the bottom one, needs to focus on differentials to most likely based on the patient's characteristics while considering high stakes diagnoses. Because we all have these students that think of zebras and they don't even think about common things being common or uncommon presentations of common illnesses. And then they miss the high stakes dissection in a patient with chest pain and focus on something esoteric. So really you want them to base it on the patient's clinical characteristics and their epidemiology. Obviously the differential for somebody with chest pain differs when it's a 20-year-old woman as compared to a 70-year-old smoking male. So here's the prime method or the synthetic framework. And if you think about it, the KSA is the analytic. It's breaking it down into its individual parts, like an H&P, all the different sections of the H&P. Whereas RIME is the assessment of the H&P, where you put all the pieces together and you come up with the most likely diagnosis. And I use PRIME because professionalism is the sine qua non of an acceptable evaluation. Even if you have somebody who's brilliant and knows the literature, manages patients well, but is unprofessional, that person can actually fail our clerkship. And we've failed students who demonstrated unprofessional behavior. A reporter can answer what questions? So if I said to a reporter, what's the patient's serum sodium? They could say, oh, it's 128. And that's all they can tell me, that the sodium's 128. On the other hand, an interpreter can give me the why. So the interpreter will actually categorize that serum sodium and say, is it hypervolemic hyponatremia? Is it euvolemic hyponatremia? Is it hypovolemic hyponatremia? So they're able to categorize the problem and show me that they're actually thinking about it and not just reporting the data. Then the manager is going to tell me, wow, this patient has hypervolemic hyponatremia due to heart failure, reduced ejection fraction, and diuretics are going to be my first treatment choice. So that manager is taking the next step of not just categorizing, but proposing management plans that are appropriate based on the category. And then the educator is actually going to use evidence-based medicine, which all of my cardiology mentors emphasized. In God we trust, all others must bring data. And you better know the exclusion criteria for the data you cite, because if that patient's going to be excluded from the study that you're citing, it's really not generalizable to the patient in front of you. So you really need to understand the literature and make sure it withstands scrutiny. And for anybody who wants more information on RIME or PRIME, I've included a link to Lou Pangaro's Vimeo on it. So what do we call a student who isn't even a reporter? We call them a wallflower. No, I'm just kidding. We call them an observer, okay? And this might be acceptable in years 1 and 2, but it is a failing performance in years 3 and 4. And we don't have residents that do this. This is more applicable to students. Well, what about the reporter? I already alluded to the fact they answer what questions. They can do a history and exam. They can document it in the clinical record and they can present it to you. And they're able to recognize normal from abnormal. They're reliable, they're day-to-day, they're punctual, they follow up. Who do reporters struggle with? Undifferentiated patients. Poor historians, unit transfers. So if you're sitting there trying to figure out, is my student or learner an interpreter or a reporter, give them a unit transfer and see if they can succinctly capture all the clinical events that are going on with that patient, or give them the poor historian. We have a lot of poor historians in the United States. You probably don't have them in Canada. I'm sure you do. And then the undifferentiated patients. And I just had a student a resident in clinic last week with a patient with new onset chest pain. And I was like, oh my goodness, he couldn't even reason through the chest pain. And it was like frightening to me because he's at the end of his 2nd year. And I've given him feedback before and he's gonna get it again after this talk. So what does an interpreter do? The interpreter answers why questions. They're able to create a prioritized problem list, and they're able to give you a prioritized differential diagnosis. And when they present to you, they present pertinent positives and negatives by history and exam, and they tell you the salient data. They don't tell you everything because it's all in the EMR. You can read it on your own. I want the Cliff Notes version of that patient presentation, and that's what an interpreter can do. They actually have more knowledge and more confidence than the reporter. And they're able to even interpret the lab studies and the radiographic studies that have been ordered. A manager takes even more knowledge, confidence, and judgment. So they're actually applying treatment and diagnostic algorithms to the patient, and they tailor it to the specific patient before them. And what I like to say here is it's anticipatory management. And one of the things that I always worry about with students is, are the residents feeding them the answers? Are they getting the answers from the resident? Did they read the MRAN and they're just presenting what the resident wrote? And so what I do when I'm struggling to figure out, are they an interpreter or a manager, I flip it around and I go, oh, how would you manage this patient with community-acquired pneumonia if their creatinine was 2.5? Oh, how would you manage the anticoagulation in this patient if their creatinine was 2.5? So I want to see if they'll remember, I can't use low molecular weight heparin. I have to use unfractionated heparin. And if I'm going to use a DOAC, I might as well use a Pixaban rather than rivaroxaban, which is predominantly renally excreted. So that's how I kind of sort out who's a manager and who's an interpreter. So educators, and this is the goal in cardiology, is that you really want to apply the literature to the patient before you, and it really requires you to critically appraise the literature. In the medical school class at USF of 170 students, we might have 1 student a year who's an educator. This is a special person. And in my residency program, the feedback I give to all my residents is that cite literature. I want guidelines and literature as the basis for your decisions. Don't just tell me what you want to do. You got to tell me why. So most of my residents that I work with in the 2nd and 3rd year, they're mostly managers. They're not educators. So I'll ask you guys now, again, you can pick up your phones. Is the assessment of rhyme part of your student evaluations at the University of Calgary? So a quarter say yes and 75, 80. All right. That's a quarter. So 75% say no and a quarter say yes. So what I'm going to do is we're going to go through rhyme cases, and I actually want you guys to assess the learner in each one of these scenarios and tell me what their rhyme level is. We'll have a question after each case. And I'm going to ask people in the audience to read each one of the cases. So the longer it takes for you to volunteer to read the cases, the longer it's going to take us to get through today's discussion. So who would like to do case 1? Just read it out loud.
attending. So tell me about Mr. Smith. Student, he is the gentleman with type 2 diabetes, hypertension, hyperlipidemia, GERD, allergic rhinitis, and BPH, who presents with a 2-week history of low back pain. It's a 4 out of 10 in severity, located in his right lower back buttock area. He woke up this morning with feeling this way. He describes it as a soreness. It radiates to his right posterior thigh. It is worse with weight bearing and walking. It is improved with rest. He hasn't taken anything for it. His exam is unremarkable. He has normal vital signs too. Attending. So what do you think is going on with him? Student, I'm not sure. I think I want to get an x-ray. Attending. Why do you want to do that? Student, it will give me more information so I can tailor a treatment plan. Attending. Does he really need to have an x-ray? Student, I think so. I can do some more reading and get back to you next week.
All right. Thank you, Dr. Kavanaugh. So I'll ask you guys, what level is this student? Reporter, interpreter, manager, or educator? You guys are good. You all got the right answer. 100% said reporter. And if you look at it, I want to kill the opening sentence. I don't know why students and residents present this way with an acute problem. That opening sentence of type 2 diabetes, hypertension, hyperlipidemia, GERD, allergic rhinitis, and BPH. I'm like, why are you telling me hypertension? Do they have a AAA? Why are you telling me about BPH? Do they have prostate cancer? Why are you telling me about type 2 diabetes mellitus? Is it osteomyelitis? I don't know. So don't give me all that information. I don't need it. They're here for low back pain. And notice they don't give any red flag symptoms. They do the old carts. They tell you the onset, location, duration, aggravating, alleviating features, associated symptoms, radiation, etc. But they don't give you any red flags. And do you trust their physical exam? Do you really trust their exam's unremarkable and they have normal vital signs? I'm not sure what that means. And then this student wants to base the treatment plan based on what an x-ray shows. And you're gonna see residents do this all the time. They're gonna do therapeutic radiation. They're gonna do a CT of the chest, abdomen, and pelvis to try to figure out what's going on with the patient rather than doing a good history and physical exam and coming up with their own differential diagnosis. All right, who'd like to do case 2? Anybody but Dr. Kavanaugh. It's the same patient, by the way.
I'll do it. Sarah Weeks here. Attending, so tell me about Mr. Smith, student. He's a 72-year-old gentleman with a history of cancer, osteoarthritis, or osteoporosis who presents with a 2-week history of gradual onset low back pain. It's 4 out of 10 in severity, located in his right lower back buttocks area. He woke up one morning with it feeling that way. He denies any antecedent trauma. He describes it as a soreness. It radiates to his right posterior thigh. It is worse with weight bearing and walking. It is improved by rest. He hasn't taken anything for it. He notes no nocturnal awakenings, incontinence, fevers, night sweats. He's afebrile and his vitals are normal. His weight is stable. His abdominal exam is benign. He has no spinal percussion tenderness, no paraspinal rigidity, normal SLR bilaterally. He has normal muscle tone bulk in his lower extremities, sensations normal, patellar Achilles reflexes are 2+, Babinski's absent, and he has no clonus, his gait is normal. Attending, so what do you think is going on with him? Student, well, I think it's non-specific musculoskeletal low back pain or lumbago, as he has no red flags, findings on history or physical. Attending, do you think he needs an x-ray? Student, I'm not sure, but I can look it up. Attending, that sounds like a good idea.
All right, thank you, Dr. Weeks. So what level do you think this person is at? Reporter, interpreter, manager, or educator? See, I knew cardiologists going to nail all these. You guys are great diagnosticians. Yes, this is an interpreter level student. And again, I want to go back to the presentation. They give you the red flags. They even gave you a differential in that opening sentence. And then they told you what they thought the most likely diagnosis was, non-specific musculoskeletal back pain or lumbago. And that is really important. And I trust this student's physical exam. Am I going to go back in the room and do every one of those features that they did? No, because they did them and they described them so well. You know you can trust them. Whereas the first student, oh my goodness, I got to go back in the room and it's starting all over again, and I got to do the whole exam. Okay. And then the next one, I won't make anybody read it, but obviously this may not be the first time this student is presenting back pain to the attending, but just work with me. So Mr. Smith is a 72-year-old patient here today for an acute visit for gradual onset low back pain for 2 weeks. He has no red flags by history or exam to warrant imaging. I think he has non-specific musculoskeletal low back pain or lumbago. I'd like to treat him with either acetaminophen or tramadol as he has stage 3 CKD with a GFR in the low 50s, so I'd like to avoid NSAIDs. The attending says, excellent observations. What would make you want to get imaging? And he goes through all the red flag features, and I'm not going to read them to you. Excellent, the attending says, I agree with your assessment and plan. Let's go see him. So let me, hold on one second. Let me let you guys rate this person. Okay. Yeah, there are no trick questions here. I'm trying to make it very straightforward. This is clearly a manager student. And notice how much time they save you. So if you're sitting there in clinic with a resident or on the wards with a clinic and you're like, oh my gosh, I feel like I'm walking in quicksand. That's a student that's not, or a resident that's not at a manager level. And then case 4 is here's where it gets into the educator level. And you'll notice that they talk about the literature saying that even in the elderly, patients without red flag features with back pain that lasts less than 6 weeks don't require imaging. The only thing imaging does is increase cost of care without improvement in outcomes. So this is a person you're like, wow, I really agree with your assessment and plan. And notice the attending says, I'd like you to lead the discussion. You can trust this person. So when we get back to that developmental model or CBD or EPA, however you want to say it, you totally trust them to the point that you want them to lead the discussion and you don't want it to be you. So how do evaluations translate into a grade? Unprofessional behavior, as I alluded to before, can lead to a fail regardless of what rhyme level you achieve. Observers are obviously a fail. And then reporters are a C or a pass, which is what we use in the United States. They get a pass grade. Interpreters get a pass with accommodation or a high pass. And then manager educators get honors, okay? And like I said, the majority of students are, if they get to manager educator, it's gonna be manager. We maybe have 1 student per class out of 170 that's truly an educator. The other thing that I wanna emphasize about rhyme is they don't exist in isolation. So if you have someone who can't present their way out of a wet paper bag, they are not a manager, even if they can come up with management plans. They need to be a reliable reporter that's an effective presenter. They need to be interpreting data and be a manager, okay? So they have to have all 3 of those. And then what do they do consistently? Because you're gonna have some residents and students who sometimes they're a manager on some cases, interpreter on others, maybe a reporter on others. So take the average of where they live and don't just base it on one isolated event. It takes me about 2 days to 3 days. And if they present to me on 6 to 9 occasions, I can usually diagnose their rhyme level. And based on your guys' responses, I think you would be able to do the same thing. So I really want you to start diagnosing the students and the residents that you work with. So now what we're going to do is we're going to review narratives, and these are actual narratives from my institution. I did not make these up. These are real narratives. And I want you to look at these narratives and say, do they have compare knowledge, skills, and attitude? Do they give a rhyme level? And do they provide meaningful feedback? And it's no audience polling, but I just want people to unmute and you can tell me which of these first 3 is the best.
The first one.
Why is the first one the best?
Well, it talks about the stage of training. It talks about their reflective ability to accept feedback. It talks about specific skills and presentation.
What grade would you assign to this person?
Don't know, that's hard off one statement. But I definitely would say that they're obviously functioning, they're at a pass. I'm not sure if that they're more than that.
Correct. So just based on this one evaluation, this could have been the beginning of the rotation, you don't know. And as I tell all students, it's not where you start, it's where you finish. And what are you consistently doing for the last half of the clerkship is very important. But this would be a pass evaluation. And in a competency-based curriculum, all students at the end of third year should be reliable reporters. If they're not, that would be considered not passing third year. And then the second one, notice it's just filled with platitudes. It's like all comments on their attitudes. I don't know what grade to give this person. And in fact, I would give this person a pass if every one of their evaluations said that, because there's no comments on skills and behaviors. And the same thing with the last one. It's all attitude, and there's no comments on knowledge, skills, rhyme level. So I'm assuming that this person is a pass. So I actually give feedback to the faculty to say, okay, let's go through these and why is one better than the other. Now let's look at the next one. And what do you notice here? Anybody? And I'll help you out, it's okay. This one actually gives a rhyme level, talks about their knowledge, talks about their clinical skills, and gives very meaningful feedback. The first three were written by residents who were not receiving evaluation sessions like our faculty. This fourth one was written by the chief of the Division of Hospitalist Medicine at the VA, a very busy person who's on the wards, going to meetings all the time. They have enough time, they wrote this. I did not write this for them, they wrote it. And I give this student a pass, just like I would have given the first three a pass, but look how much more information this student has to improve. Look how much more information the competency committee has to give feedback to the resident about how to improve. It just doesn't say an average performance, it actually gives specific details for continuous quality improvement. So that should really be your goal of your evaluations. And what we tell our faculty is, let us worry about assigning grades. We want you just to diagnose the learner's level with rhyme. And the one thing to make this successful that you need to do is we do not allow students to talk to faculty and residents about their evaluations. If they feel an evaluation is unfair, they can't approach them, they can't email them, they can't text them. We tell them that in orientation, they have to approach us, and we'll be their legal team representing them, and we'll speak to the faculty or the resident about it. And what I tell all the students is I look for patterns. If there's a pattern described in the evaluations and there's 10 over the clerkship and they say the same things, then I got problems. Whereas if it's one outlier, I'll do fact finding and figure out what's going on. And again, you guys are cardiologists, you want data. So here's national data. We asked all the clerkship directors in the United States, what are important components in a narrative evaluation? And you could see that there was 100% agreement on describing skills and behaviors. Again, this was 128 institutions. We had 95 institutions respond. It was a 74% response rate. So they really want to hear on skills and behaviors. In the free text comments they provided, they wanted specifics and they wanted it observed. So, you know, everybody wants faculty to observe, but they got to give us the time to do it. And I don't know how things are at the University of Calgary, but at USF, we have to really take things, we take what the students say and the residents say, and we can't watch them. I wish I could. I might watch part of a history, part of an exam, but I'm not watching an entire H&P. But you do really want to focus on skills and behaviors in your narratives. And then you want that overall synthetic level of the student that they can put all the pieces of the puzzle together. Notice comments on attitude and personality were next. Adjectives weren't that highly rated because I don't know what excellent means anymore. There's this Lake Wobegon effect where everybody's at least very good or better. And I have some institutions that tell me outstanding doesn't mean outstanding anymore. They want to hear most outstanding, which I'm like, wow, that's not even good grammar. So that's why adjectives really aren't as helpful. And you can see length was the least valued of those things. And I have faculty members who in 3 lines can give me compare KSA, rhyme, and meaningful feedback in 3 lines on an evaluation. So when you sit down to do it, you're like, how am I going to start? Just remember, compare KSA, rhyme, meaningful feedback. So now what I'm going to do is switch gears, and I'm going to talk about the using the data we get from our evaluation system to motivate faculty to improve their evaluative and their teaching performance. So we use an evaluation platform at the University of South Florida called eValue. I own no stock in the company, but they're able to generate reports that can rank your faculty from 1 to 50. They can give you reports that tell you who are your hard graders, who are your easy graders, and then they'll actually look at student evaluations in the domains that the students rate faculty by to figure out what are areas faculty need to work on. So Dr. Kavanaugh, and also on the calendar invite for this Zoom meeting, sent a portfolio. So within that portfolio is this rank report. And what I do is I blind it and I individualize it. So John Smith only sees where he is on the spreadsheet, and he sees no one else. And when he looks at his leniency and stringency report, he sees the same thing, only his name and no one else. We also give them an individual to group comparison report that looks at the 10 domains that students rate faculty by. And I'm going to show you how we coach faculty up to improve their performance in each of these individual domains. And the carrot at the end of the stick, and the reason why faculty come to the meetings I alluded to before, is they want to actually see the verbatim narrative comments from the students. So they've worked with like 50 students this year, and they want to read those comments. So they show up just for that. I'm also going to talk about the leniency and stringency report. We use the saying in the United States, hawk versus dove. And the goal on this report is to be between -3 and 3. And this is what eValue tells me. This is not me coming up with the idea. This is what their experts have told me. They haven't given me literature on it, but that's what they tell me. So I'm going to show you one faculty member. We're going to call him Dr. Awesome. And these are compiled based on student evaluations for an entire year. So I do this annually, and all the students that they work with, they get ranked. And you can see the Lake Wobegon effect is seen in students as well. Our worst faculty at the bottom is a 3.85 on a 5-point Likert scale. That faculty member actually got taken off the wards because they were so bad. Yet that person only was a 3.85 out of 5. So you can see that the check boxes may not be as valuable as you think they are. So I'm going to pick on Dr. Awesome because he won Best Teacher for 5 years in a row. I'll reveal his name to you in a little bit. But he won Best Teacher 5 years in a row. And you can see he worked with a number of students. And his average score was a 4.82 out of 5. So what is in Dr. Awesome's packet is just his name on that rank report, but then we give him this individual group to comparison report, and it breaks down the 10 different domains. For sake of time, I'm not going to go through all of them, but what we want every faculty member to do is self-reflect and look at this comparison report and look where you're at the group mean or below the group mean and say, wow, that's an area I need to work on to get better. And when they look at the rank report, I tell them, I don't want you to sit there and pat yourself on the back if you're at the top. I don't want you to be angry if you're at the bottom. I really want you to look at the individual group to comparison report and say, wow, I need to get better. And even Dr. Awesome is not perfect. He needs to observe the students doing H&Ps more. He needs to give more teaching on write-ups and presentations. So these are things that he needs to do so that he can become more awesomer. So this leniency and stringency report I'm going to show you now, but essentially what it does is it compares how you rate one student and how every faculty member in our college rated that same individual student. And it comes up with a number that says, are you a hard grader or are you an easy grader? And I'll show you the report in a little bit, but I have a question for you first. Do you think lenient evaluators receive higher student rankings? All right, so we say, some people say lenient graders are ranked higher. A third of you say stringent graders are ranked higher, and about half of you say there's no effect. As cardiologists, I should know better. You guys are slick. Now it's gone to 40. Okay. So here's where Dr. Awesome sits on that leniency and stringency report. Now, the more negative you are, this is just based on the tick boxes, the individual Likert scale scores. And the more negative you are, the more harder of a grader you are. Your goal is to be between -3 to +3. And then you can see the doves at the bottom. I really don't think the term hawks applies. I think a different H word applies, and that term would be honest. And I think that the doves at the bottom, my goal is not to make the doves cry, but I do want the doves to actually give more meaningful comments than, oh, this is the best student I have ever worked with. I actually want you to give me a denominator in the last month, in the last year. Why are you saying that? In the last 5 years, you got to give me data. And if you keep telling me every student walks on water, you're going to get a phone call from me or Bobby Ledford asking you why you're saying that. And I've tried to do this every year. I can safely tell you I haven't had that huge of an impact. I've made some of the doves put better comments in their evaluations, but I really haven't changed the stringent people, and I don't really want to. So here's the faculty rank on the left, or excuse me, the evaluator leniency and stringency on the left, and evaluator rank on the right. And what you can see, there is no correlation. So for the 50% of you that said there was no correlation, you were correct. There is no correlation between leniency and stringency. And the students actually value what you write more than what you check. And that's validated by international studies that I wish I could share with you today, but the students really want the comments over the boxes. And I'm going to close things out today by talking about high quality teaching habits and educating everybody on teaching habits to aspire to and teaching habits to avoid. And I typically will mix things up every year. I always talk about rhyme. I always show them evaluations. I always go over the portfolios, but every year I try to switch it up so I don't talk about the same things. But one of the things I discussed early on was high value teaching behaviors and low value teaching behaviors. So I'll ask you guys, give me examples of high quality or high value teaching behaviors. You'll probably think of your mentors. Explicit. That sounds like they gave expectations up front. I like that. And they were honest. Honest feedback. Ways to improve. Timely feedback. What else did they do at the bedside that just knocked your socks off from teaching perspectives? And I believe you can put in more than one comment. They observed you. Exactly. They made you critically think and reflect. They listened. Exactly. My mentor, Chandra Mohan, oh my goodness, he made me want to go home and read more after I rounded with him. It was like a religious experience. He was sitting there dropping pearls all over the place, but he taught you at the same time. And even if you were wrong, he never made you feel like you were a failure. Never did. right. So here are direct student evaluations from USF. Okay. Just to emphasize these points. And I think you'll find these extremely valuable. And I would encourage you, all the things you said in your free text comments, but I also want you to gravitate to these as well. There's that feedback again. There was that clear about expectations that you guys said with explicit, and feedback was the most common comment that you guys had, okay? And wouldn't make you feel like a failure. They were honest, just like you said. They even gave mini lectures on certain topics that were incredibly helpful. They were an amazing role model. Their passion was contagious. They observed you taking a history. All the things that you guys said. And common sense, you know, is not so common. I really want you to say to myself and reflect, am I doing these things, or am I letting time change the way I practice medicine? Because we're all pressured for time, and I would encourage you not to think about time, but rather model behaviors that you want them to display to you if they ever take care of you. So now I'm going to ask you, and switch gears, what are some examples of low quality or low value teaching behaviors? And the way I like to think of this one, shame-based learning. The way I like to think about this one is Abraham Lincoln has this awesome quote that says, I've learned something from everyone I've met. It's usually what not to do. And so I sat there as a resident and I studied every attending that I work with, every resident that I worked with when I was an intern. And I said, these are habits I want to be like, and these are the ones I'm going to avoid. And I sit there and I would watch them and observe them. Never checked what I did. They felt rushed, shame-based. Bingo. The best teachers explain the why. And not only that, they explain it in such a simple term that it's so easy to remember that you can explain it to someone else later. It's not in some fancy terms that no one understands. Exactly. Beautiful. So here's the faculty member that I told you. Why don't you look it up and tell me? I love that one too. You know, it's better than that is just saying, I don't know. Those are the 3 or 4 smartest words in the English language. Show some humility. You can't know everything. There's nothing wrong with that. I would much rather hear that said than, why don't you look it up and tell me? And I say, I don't know all the time. So here's that faculty member that got pulled off the wards. And it's sad. Again, her Likert score was a 3.82 out of 5, but she really struggled with efficiency. She really struggled with organization. She really struggled with fund of knowledge. She had a heart of gold, but she would sit there and ask team members on rounds just before they walk in the team room, can you look this up on your phone? And then whatever they told them, she would go in the room and talk to the patient and say the things they told them after she had looked it up. They had looked it up on the phone and told her about it. And it's like, whoa. And we kept getting this repeated feedback over and over again. And at our institution, we say, working on the wards is a privilege. It's an earned privilege, and it can be taken away. And that same attending still works at USF, but they are on the non-teaching service, and they've been on the non-teaching service for the last 6 years. We had another attending who was shameful teacher that was described before, and would do it all the time, and even got feedback from leadership saying, stop doing this, you're brilliant, but stop shaming people. Wouldn't change, wouldn't change, wouldn't change. They just put him in clinic, and he saw clinic by himself. And then they kept reducing his salary because he was tenured, and he ultimately left USF, okay? So I'm telling you right now, use these evaluations from your learners to give feedback to your faculty. I think it's very important because learners are going to tell you things that you may not hear otherwise. So high value and low value teaching behaviors. Again, let's look at some literature. This is an older study from Dario Torre at the University of Pittsburgh in 2005, but they used PDAs back then because they didn't have smartphones, and they looked at almost 2,700 teaching encounters and they had students pick from a list of what were high value teaching behaviors. And what they found is the 5 things in univariate analysis that were helpful: teaching during conferences, bedside teaching, giving mini lectures, teaching skills. And cardiologists, you guys have lots of things you can teach, whether it's X-ray interpretation, EKG interpretation, echocardiography, how to interpret a swan when you're doing a right and left heart caths. Those are all teachable skills. So that's ripe for the taking. And then giving feedback. And you can see that teaching clinical skills and feedback on multivariate analysis were extremely helpful, as were the mini lectures. And if you don't have time to give mini lectures, my cardiology attendings in my residency program gave us handouts that were chock full of the latest literature. And I read those over and over and over again and started citing them. And that's what you want to do, so that you can come up with creative solutions, even if you're pressured for time. So this will be my summary slide. Hopefully after today's discussion, you'll see that the annual group sessions we do here at USF improve faculty knowledge of rhyme or prime. It gives faculty a framework that they can assess students' skills. They make a faculty aware of their evaluation tendencies, and we try to educate faculty on their own high value and low value teaching behaviors. And what I want you guys to think about now is I want you to reflect on what we've talked about today. I want you to brainstorm about the current system at the University of Calgary. What are interventions or processes that you can do that could improve the quality of the evaluations that your faculty submit? Because I'm telling you right now, if you sit there in a competency committee and say our evaluations stink, guess whose fault that is? It is not the faculty's fault, it's yours. So you got to take it upon yourself to improve the performance of your faculty. And what are the barriers to providing faculty feedback on their performance at your institution? So those are questions that I want you guys to ponder. And with that, yes, I just gave you feedback. Are there any questions or comments that you have for me?
If not, I'd like to thank you very, very much. Any questions before we have to say goodbye, because I know we're over time? We will be having Dr. O'Brien join us for our retreat, as I said. And thank you, everybody. And I hope you enjoyed his presentation as much as I did today and previously. Thank you again, Dr. O'Brien, for such an insightful presentation.
I'm sorry I ran late. I didn't mean to do that.
Oh, that's okay. That's okay.
I carried away.
A lot of people just stayed around. It's great. Thank you.
Yeah, if anybody has questions, I even have data to show you, is there an effect of what we do? I'm happy to show it to you.
Thanks, Dr. O'Brien. It's Sarah Weeks. I do have a question. You and I have discussed this in the past, and the elephant in the room of this was the professionalism piece, which we didn't really get to, which, you know, faculty really struggle to, one, maybe they identify, but they struggle to articulate, provide feedback, and potentially flag, you know, that learner as needing, you know, some additional support and to be kind of tracked a little bit. I'm wondering if you could comment briefly about that and the kind of failure to report from a faculty perspective.
Great comment. One of the things that we do is on our evaluation form, we have a section that says comments not to be included on the medical student performance evaluation or dean's letter. So that faculty can provide those kinds of comments that won't show up on the MSPE. So that's where we get a lot of those professionalism comments. And talk to the faculty about what unprofessionalism is. And we specifically talk about failure to report, failure to show up, can't be, never seems to be available, always submitting their work in late, not being interested on rounds, et cetera, et cetera. So we really emphasize that to faculty as well, but it has to be on the evaluation and put it in an area where it's, you can say it without offending the students, because they're all worried about their MSPEs and getting into residency training. So when you put it down there, it carries less problems. And then I tell faculty, you got a problem? Here's my phone number, text me or email me and let's have a conversation. And don't wait till the end of the clerkship. Tell me within the first week, tell me within the first several days. I want to know about problem people early rather than late.
Thank you.
Any other questions? I don't know how. Go ahead.
Okay, I think we still got some people here. Any other questions?
I'm gonna
Anybody want to see his data?
Yeah, I'll show you the data because it does work. After 4 years of doing this, and as my mentors taught me oh so well, make things that count at least twice. If you're going to do it, you should study it. And so what we did is I sent a 6-item survey to all the faculty in the college, and I got 42% response rate. And I asked them, are you familiar with RHYME? Because I was doing these development sessions in only 2 departments, family medicine and internal medicine, and everybody else was left up to their own, what they do, which is nothing. And you can see that going to the sessions made you more familiar with RHYME, you were more likely to use it, you felt more objective when completing evaluations, you would actually receive feedback on how you evaluated, and you were satisfied with the evaluation process. And we took that one step further, and we even qualitatively analyzed their narratives. And again, you can see the numbers. I just finished this manuscript that I'm about to submit, but the bottom line is it does work, and it requires passion and persistence. You got to do it regularly. You can't just do it once. And you got to remind people year after year after year.
Okay.
Any other questions?
Okay, I think I better let people get to their other duties.
Yes,
And
ma'am.
thank you very much. And we'll reconvene for RPC at noon our time.
All right.
Okay, thank you again. Bye
All right.
now.
Bye-bye.